Can we start?
Yes, sir.
Okay. Can you see the slides?
Yes, sir.
Okay.
Is the first slide, sir?
Can you see the slide?
Yes, sir.
Okay, we'll start now. So
If any problem, I'll come.
today topic is the treatment of Leishmaniasis. I hope you have studied in your parasitology class the life cycle of Leishmaniasis. As you know, this is the result of bite of the sandfly. Part of its life cycle will be undergoing in the sandfly. Then part of it is in the human host. In the human, the parasite is intracellular inside the macrophages and they are called mastigates. Now this is endemic in tropical regions, India and Nepal too. And this Leishmaniasis will give rise to visceral Leishmaniasis, that is called Kala Azar, or cutaneous Leishmaniasis, and topical Leishmaniasis or the sore. Now coming to the drugs for Leishmaniasis. This Leishmania control is governed by what is called as National Vector-Borne Disease Control Program. This is a national program intended to eliminate Leishmaniasis. As I said, it is endemic in certain tropical countries, including India and Nepal. And we have to follow the guidelines given by this committee, National Vector-Borne Disease Control Program Committee. Now, according to that, there are 4 drugs which are available for the treatment of Leishmaniasis. The foremost drug is sodium stibogluconate. Sodium stibogluconate. Second drug, amphotericin B. Third one, miltefosine. Fourth one, paramomycin. Now you cannot treat this Leishmaniasis blindly. You cannot guess and treat it. Only confirmed cases, because these drugs are toxic, number 1. Number 2, they should be given for a longer period of time, weeks together or months together. They are toxic. So that's why only confirmed cases of Leishmaniasis. How are you going to confirm them? By rapid diagnostic test or by splenic aspirate examination. So diagnosis also you have learned in your microbiology classes. So only after confirmation you have to use the drug as per National Vector Disease Control Board directions. Vector-Borne Disease Control Program. Now after having this introduction, let us study the drugs one by one. To start with, sodium stibogluconate, which is abbreviated as SSG. This is the first line of drug for the treatment of visceral Leishmaniasis, that is Kala Azar, in most part of the world, but not in India and Nepal because of resistance. The parasite got the resistance against this drug. The inhabitants of Nepal and India, they don't respond for this drug. Rest of the country, this is the first line of drug or drug of the first choice. Now coming to the mechanism of action. Now this stibogluconate, sodium stibogluconate is a water soluble compound. What is its chemical nature? It is an antimonial compound. It is a pentavalent antimonial compound. Now this antimony, it inhibits sulfhydryl dependent enzymes in the parasites. What will happen when once these enzymes are inhibited? The bioenergetics of the parasite are interfered with. The biological phenomenon to generate the energy, they are interfered. That is one mode of action. Then second mode of action, there are specific enzymes, specific reductase enzyme present in Leishmania amastigotes. As I said, these amastigotes, they are nothing but aflagellated intracellular parasites which are seen in the macrophages of the human host. So these amastigotes, they contain a specific reductase enzyme. Now this enzyme reduces pentavalent antimony compound, that is sodium stibogluconate. So this pentavalent is reduced to trivalent form. This trivalent form is toxic. So what it does, the toxic material, that is a trivalent form, it promotes efflux of glutathione and other thiols from the parasites residing in macrophages. And when once these glutathione and thiols are effluxed, that means they goes out of the parasitic cell, and that parasite is exposed to the oxidative damage of the host mechanism. So there are two phases or two types of or two-dimensional mechanism of action. First dimension, it will inhibit sulfhydryl group of enzymes which will interfere with the generation of bioenergetics in the parasite. Second mode of action, this reductase enzyme present in the amastigotes, they reduces pentavalent antimonial to trivalent form, and this trivalent form is toxic to the parasite. In what way it is toxic? It promotes efflux of glutathione and other thiols from the parasite which are residing inside the macrophages. It will expose them to the oxidative damage. Now coming to its pharmacokinetic properties. The drug is given parenterally, particularly deep intramuscular. It is highly irritant to the muscles. That's why you have to give in the gluteal region, in the gluteus maximus muscle, deep. So from that side it is rapidly absorbed and it is excreted unchanged in urine within 6 to 12 hours. A small fraction enters the tissues and remains stored for longer period of time. That's why the repeated dose is cumulative, because you have to give them in repeated doses. Since it is stored in tissues for a longer period of time, so it causes cumulative toxicity. What are the adverse drug reactions? Even though the drug is given parenterally, it causes nausea, vomiting, metallic taste, cough, abdominal pain, and particularly pain and stiffness in the injected muscle. As I said, it is highly irritant to the muscle. Even though you are given into the deep muscle, deep into the thick muscle, that is the gluteus maximus, it causes pain in the site of at the site of action and stiffness in that muscle. And sometimes it can cause sterile abscess. Even though you have taken lot of aseptic precaution, the area is not affected. Since it is irritant, it causes abscess. This abscess is sterile, it is not infected. So it can cause sterile abscess. In that case, you have to drain that by incision and drainage. And more toxic effects are QT prolongation, then arrhythmias, and cardiogenic shock and death. That's why I said these drugs are very toxic. Unless the case is proved positive by diagnostic test, you cannot use this drug. What is the dose? 20 milligram per kg intramuscularly or very slow intravenous. Why it is slow intravenous? Because it causes arrhythmias. It causes QT prolongation on ECG. It is causing cardiogenic shock. So you have to monitor the cardiac function and slowly inject intravenously. And it is given for 30 days. That's why I said, first of all, drug is toxic. You have to give them for a longer period of time. So that's why you can give only to the confirmed cases of leishmaniasis. Now, second drug, amphotericin B. So the first drug, sodium stibogluconate, it is not effective in Nepal and India. So if you are practicing either in Nepal or India, you cannot use that drug. The next drug is amphotericin B. It is abbreviated as AMB, amphotericin B. Now, what is the nature of the drug? This drug is polyene. It is antifungal and it is an antibiotic. Antibiotic, that means it is obtained from certain organisms. What are these organisms? Streptomyces nodosum. So it is obtained from these biotics, the living organisms, but it is lethal to other living organisms in a very minute concentration. It is antifungal in nature. Chemically, it is polyene. Now, what is the mechanism of action? Now, these polyene antibiotics have high affinity for ergosterol present in the cell membrane of the fungus. Similarly, Leishmania, the parasite also has got ergosterol. For that, polyene has highly affinity. Now these polyenes, they combine with the cell membrane because of this high affinity, then get inserted into the cell membrane. It will be incorporated into the cell membrane, and where they are incorporated, they form a pore, a hole-like structure in the cell membrane. It's called micropore, minute pore. When there are minute micropores in the cell membrane, the permeability of the cell is markedly increased. That is, the parasitic cell membrane becomes permeable. As a result, ions, amino acids, and other water-soluble substances, they will come out of the organism come out of the parasite through these micropores. And as a result, the parasite will die. It cannot sustain, it cannot survive. As I said, like fungi, Leishmania has high percentage of ergosterol. That's why it is susceptible. The same thing, it will incorporate with the membrane, causes micropore, the contents will come out and the parasite will die. Now this amphotericin B is available in two forms. There are two types of preparations. One is older, other is newer. What is this older? It is amphotericin B in the form of deoxycholate. Amphotericin B deoxycholate. This is the older form. It is less expensive. The newer form, it is liposomal amphotericin B. That means liposomes are used as carriers. The drug is injected into the liposomes and these liposomes are injected into the body. And these liposomes, they will go to the target site. That's why it is expensive. They have to do, first of all, they have to grow the liposomes outside the body and they have to incorporate this amphotericin B into the liposomes and they should be injected into the person who is suffering from Leishmaniasis. And because of this pharmaceutical procedure, the drug is expensive. It is newer preparation. It is liposomal amphotericin B, which is abbreviated as LAMB. Now this amphotericin B is more effective. 99% cure rate is seen in India and Nepal because sodium stipogluconate is not effective. The organs have got resistance. So you can use amphotericin B where the cure rate is 99%. So not only in India and Nepal, wherever the cases where they are resistant for sodium stipogluconate, this drug is effective. Cure rate is 99%. The drug is highly toxic. So because of that, whenever you are giving this drug, it needs prolonged hospitalization. You cannot give it on a OP basis. You cannot administer to an ambulatory patient. Patient should be hospitalized and he should be monitored for its vital functions, cardia, blood pressure, respiration, etc. Then repeated slow IV infusion. The drug is given by intravenous. Slow infusion, it is injected along with normal saline or glucose slowly and repeated dose. Now coming to the dose, that is liposomal amphotericin B, total dose is 15 milligram per kg. And this amount of drug is administered over 3 to 5 days by slow intravenous infusion. As I said, cure rate is approximately 99%. What are the conditions where it can be used? Visceral leishmaniasis, that is Kala Azar, mucocutaneous and dermal leishmaniasis. Miltefosine, the third drug. This is a derivative of alkyl phosphocholine. Alkyl phosphocholine. This is also potent anti-leishmanial activity. This is also potent anti-Leishmanial drug. This is the first drug which is given orally, because you have seen the previous two drugs. They should be given parenterally. Intravenous amphotericin B, stiboglucolate, it can be given deep intramuscular or intravenous. Miltefosine is the first drug which can be given orally against Kala-Azar, that is visceral leishmaniasis. And this is also first line of drug under National Vector-Borne Disease Control Program. Why is first line of drug? Because it can be given orally. Number two, hospitalization is not required. And this drug is available only through that program. It is not available outside for the prescription. Through that agency, National Vector-Borne Disease Control Program, through that agency only it is available. Now what is the course? 4-week course has achieved more than 95% cure rate in India and other countries. So the course is 4 weeks. Now what is the mechanism of action? Now this drug interferes with the lipid metabolism of the parasite. That is, according to one theory, it interferes with the lipid metabolism of the parasite. Or it will prevent the synthesis of some critical cell surface anchor molecules. Cell surface molecules. Or it will alter the signal transduction. So definitely not a single mechanism is identified. It will be either it is interfering lipid metabolism, or it will prevent the synthesis of cell surface molecules, or alter the signal transduction. As a result, the organism or the parasite cannot survive. Now for this drug, resistance may develop, because you have to give it for a 4 weeks time. So in that it may get resistance. Organism can get resistance. Therefore, combination therapy with other drugs is promoted to prevent resistance. You have to give as multi-drug therapy in combination with other drugs like paramomycin or amphotericin B. Now coming to its pharmacokinetic properties, it is given orally. As I said, this is the first drug against visceral Kala-Azar to be given orally. When it is given orally, well absorbed, widely distributed, plasma half-life 1 to 4 weeks. Cumulative again. Astrodrug reactions, anorexia, vomiting, diarrhea, skin allergy, hepatitis, kidney derangement, but it is reversible. That means if you stop the drug, after some time kidney will start functioning normally. It is teratogenic. So any drug which is teratogenic, it cannot be given during pregnancy. So it is contraindicated in pregnancy. Next is paramomycin. That is the last drug, paramomycin. Now this drug is aminoglycoside, just like streptomycin, kanamycin, neomycin. This paramomycin, this is aminoglycoside. So this is antibacterial. It is a bactericidal antibiotic. This drug is also used parenterally, particularly for visceral leishmaniasis. For cutaneous, it can be used topically. Now, what is the mechanism of action? It is bactericidal. Similarly, it is parasiticidal. It will bind to the ribosomes of the parasite, resulting in inhibition of protein synthesis. So, the parasite will die. It is parasitocidal. What is the dose? 11 milligram per kg per day for 21 days, 3 weeks program. Cure rate 95%. All aminoglycosides, they are toxic. They are nephrotoxic. They are ototoxic. So ototoxic, deafness, but it is reversible. If you stop the drug, after some time you will recover. There is elevation of serum transaminase. Hepatic enzymes are also interfered with. Pain at the site of injection because you are giving it parenterally. So at the site of injection there is pain, and is renal toxic also. Again, it is reversible. So parenterally it is used for visceral leishmaniasis, that is Kala Azar. Topically, application at the local site, dermal leishmaniasis, the ulcers, the sores. So on that you can apply locally, topically. We are talking about combination therapy because number one, already in Nepal and India for sodium stibogluconate, that already organs are got resistance. So similarly, if you use this single drug, there may be emergence of resistance in other conditions, other countries also. That's why we advocate, or the committee advocates, the combination therapy. What are the advantages? Advantage of therapy, advantage of combination therapy. They will limit the risk of development of drug resistance. You can avoid emergence of drug resistance. Then reduction of overall dose, because you are using more than one drug and they are synergistic in action. As a result, the overall dose of each drug can be reduced. Number three, attains higher efficacy and cure rate more than 99%. Number four, shortening of duration of regimen, because you have seen that sodium stibogluconate you have to give for 30 days. The amphotericin B you have to give for 3 to 4 weeks. So if you use combination, the number one, dose can be reduced, the duration also can be reduced. Now what are the regimen available? Number one, that is liposomal amphotericin B, 5 milligram per kg intravenous, plus miltefosine orally daily for 7 days. You see, now from 3 to 4 weeks or 30 days, the duration has come to.
Light is coming.
Can you hear me? Hello?
Yes, sir.
Okay. So, combination therapy, dose is reduced, 5 milligram per kg intravenous and miltefosine daily for 7 days. That is one regimen. Or liposomal amphotericin B, 5 milligram per kg intravenous single dose combined with paramomycin intramuscularly daily for 10 days, or miltefosine oral combined with paramomycin intramuscularly daily for 10 days. So this is the combination therapy, and these are the advantages. The risk of development of resistance is avoided, reduction of overall dose is seen, attains higher efficacy and cure rate, that is 99 up to 99% of cure rate, shorten the duration of action of the therapy, 10 days, 7 days to 10 days instead of 3 weeks to 4 weeks. Dermal leishmaniasis, where you can see the ulcers, sores. Now what is the treatment? Kala-Azar is a life-threatening, whereas dermal leishmaniasis, it is not life-threatening. It is not an emergency. Local application of the drug is enough. Topical application. So, number 1, sodium stibogluconate. 2 ml of the drug is infiltrated around the site, or paramomycin 15% concentration ointment, topical application twice a day for 10 days. If there are multiple sores all over the body, mucocutaneous region, if there are multiple sores and these sores are very severe, then they should be treated with systemic drugs, just like visceral leishmaniasis, that is Kala-Azar. Parenterally, you have to give the drugs because number 1, the sores are multiple and they are very severe. Now sometimes these wounds, the sores, may be infected. It is called secondary infection. In that case, in addition, you have to use antibiotics. In addition to anti-leishmania drugs, you have to use antibiotics because these wounds are secondarily infected. With that, we have concluded the topic on anti-leishmania drugs. Any doubts? Yes, can you hear me? Any doubts?
No, sir.
Okay, these are the some SAQs, assignments. You have to complete it. Describe the treatment of visceral leishmaniasis. Describe, that means the regimen, combined therapy. When once we say the treatment, the drug, dose, route, frequency, total duration. Then write descriptive notes on individual drugs, sodium stibogluconate, amphotericin B, miltefosine, paramomycin, and dermal leishmaniasis. As far the drug is concerned, as I said, their group, chemical nature, mechanism of action, adverse drug reactions, uses, contraindications. Then coming to the disease, dermal leishmaniasis, you have to, in 3 or 4 lines, you have to say what is dermal leishmaniasis, what is the nature of ulcer, their site, their appearance, etc. Then which drugs can be given. As I said, few sores, topical application of paramomycin twice a day for 10 days. If there are multiple ulcers, severe, then you have to use parenteral drugs combination, just like visceral leishmaniasis, and if they are secondarily infected, you have to use other antibiotic for the treatment of secondary infection. Okay, with this we have concluded this topic.